My name is Kelly Talby. I'm the Director of Policy and Strategic Partnerships at Kentucky Voices for Health. And today we are joined for the first in 2026 forum with the Cabinet for Health and Family Services. We are joined today by Cabinet Secretary Dr. Stephen Stack, Technical Project Specialist with the Department for Medicaid Services, Angela Sparrow, the Program Director of the Office of Rural Health Transformation, Tom Walton, Special Projects Manager and 1959 Specialist with the Department for Behavioral Health, Developmental, and Intellectual Disabilities, Tanya Dickinson. The Assistant Director within Health Plan Oversight at the Department for Medicaid Services, David Very. And I believe also the Director for Family Support, Division of Family Support within the Department of Community-Based Services, Roger McCann. So we would like to warmly welcome everyone today, as well as all of you all in our March 16th forum for the state and federal policy updates with Thrive Kentucky. You can go on to the next slide. For those unfamiliar with Thrive Kentucky, maybe you haven't joined us in a while or it's your first time, here are some of our principal statements and what helps drive and inform our work. We want to remove barriers. We want a strong safety net that is a welcome mat philosophy and approach that makes it a possibility for every Kentuckian to have their basic health-related social needs met. And if you go on to the next slide, you'll see our steering committee members here. These are just a few of the folks that you see in the room. They also will help facilitate the conversation with our cabinet leadership and members today. And if you're not already following us individually, apart from the coalition, I encourage you to do so. You can go on to the next slide. If you're not yet sponsoring or partnering with Thrive Kentucky, we would love your support. I'll drop my email in the chat here in just a second, but I would love to talk to you about how to spend your money wisely in ways that make Kentucky a healthier place. You can go on to the next slide. Here are a few upcoming dates. If you've not yet registered, if you don't have it on your calendar, to please mark these down for our virtual series. And soon to come, we will be announcing our in-person roadshow and where those locations will be throughout the state in 2026. You can go on to the next slide. Just some housekeeping before we get started. Please keep your lines muted. We have adjusted how we secure and manage the back end so that we don't have some unwelcome guests within our Zoom room. So you should hopefully only see the individual speaking or the slide deck that is being shared at that time. We encourage you to please drop your questions and comments in the chat as we go. I guarantee you, if you have a question, someone else was probably thinking along those same lines. And so we like to try to get to them in live time so that everyone benefits from hearing the answer. If you are in need of continuing education units for today's webinar, there will be a survey in the email to follow from Alex, and that will include a recording from today, the slide deck, additional links and materials, and you will have to complete that evaluation in order to receive your CE certificate. And with that, here is our agenda for today, and I'm going to hand the virtual mic over to my good friend Dustin Pugel to kick us off.
All right, thanks, Kelly. My name is Dustin Pugel. I'm the Policy Director at the Kentucky Center for Economic Policy. And we wanted to start just by checking in on a couple of areas that we haven't been able to give updates on in a little while. We wanted to start by talking a little bit about the Rural Health Transformation Fund. This is something that in our previous forum with our friends at the Cabinet, we were able to announce that Kentucky's plan had been awarded, that we were actually awarded a pretty large amount of money, over $200 million this year, to implement 5 main program areas within that fund. And so today we have the Program Director for the Rural Health Transformation Program, Tom Walton, to share a little bit about the beginning stages of implementing that plan, and then also where folks can find more information on it and how to plug in. So Tom, I appreciate you joining us today. I was hoping maybe you could share a little bit about that.
I would love to share a little bit about that. So I'm going to be fast. Just a timeline here. So on December the 29th, Kentucky was awarded $212.9 million. I'll refer to that to $213 million just for a little rounding there. Between the 29th and February the 5th, we were going back and forth with CMS. As many states have learned, CMS wanted to clarify exactly how the money would be spent, et cetera. So on February the 5th, we were the 213 million became unrestricted, which means that we can spend against it. A couple other really important timelines for us is that on July the 31st is the end of our first reporting period. And then based on what we've accomplished between January the 1st and the July the 31st is that will impact how much funding we received in budget year 2. And then another very important date is by October 30th of 2026, we either have to have spent or obligated all of the $213 million. So the image that we're using here is that we're sprinting a marathon, because as we sprint, we have these objectives and key results for each of the initiatives, which I'm going to talk about, which guide our pathway on this marathon. One thing I do want to really emphasize, though, is that, while we talk about the 5 initiatives, we call them our verticals, in reality, they are all connected together. So please don't think that when we talk about chronic care that we're only talking about chronic care, because we know that a lot of the technology infrastructure that we're building under the chronic care initiative is certainly applicable to all 5 of the initiatives. The key to, as we provide updates, we're updating the website. So that is the place to go to for funding announcements, for program updates, and et cetera. And there is a form on there that we'd like you to fill out that keeps us informed of all the people around the state that want to know more about the Rural Health Transformation Program. I'm going to hit on the 5 initiatives just very quickly. The first is Rural Community Hubs for Chronic Care Innovation. We have decided to focus on diabetes and obesity as our first chronic condition. And we know that lots of things underlie chronic conditions. So that's, we've just focused on diabetes there. And again, what we really want to do is reduce diabetes and obesity through evidence-based practices there. A phrase which is extremely important to us is locally led, state enabled. So throughout all of the rural health programs, we're going to be listening to the voice of the community and incorporating that as we really co-design the programs with them. I have talked about the increased technology that we're using. We're going to spend a lot of time thinking about how to enhance Connect resources. The Kentucky Health Information Exchange is moving to a new platform in next week. So we'll be looking at ways to optimize that platform. And generally, a theme that you'll see throughout our work is to optimize, state resources. The next initiative is the Powering for Maternal and Infant Health. There we're looking at what we call power teams. So as soon as, we receive notification that a lady is pregnant, there'll be this method to connect that household with a care team, which we think will have a community health worker, a doula, and again, certainly an OBGYN to help them navigate through that period of pregnancy. We'll also be looking at optimizing existing programs like HANDS and community health workers, et cetera. The next one is called Rapid Response to Recovery. There we're looking at establishing 2 more empath unit. Empath is again, I come from the hospital world, but sort of a short stay outpatient observation unit that has a very intense connection to community-based resources. So one of our objectives there is once a person presents to the empath unit and receives care, that in fact we arrange community resources to follow up there. The next one is Rooted in Health, which is dental health. We're looking at expanding the public dental, certainly the number of dental hygienists, the number of public health dental hygienists, and also the use of, we're using the generic term teleservices so that hygienists in the community can be connected to they're probably the academic medical centers to work with dentists there. And the last is the crisis to care. We're looking at the emergency medical response system. We're also looking at how to increase the regional medical operations coordination centers so that if there is some kind of trauma in the community, then we'll have a regional coordinated response. So that was a very quick view. Again, what we're telling lots of people, the best way to get involved with us is to look at the website. The other thing I'm asking people is to actually read the application. It's 60 pages long, but at the end of each description of initiative, there's a table which are our objectives and key results. So the more that individuals can tell, how their products or services are tied back to those objectives and key results, that's really important to us because then that's what CMS is going to be using to grade our application. The money is at risk for really two reasons. One is that if we don't spend it, and the second reason was if we are not able to meet our objectives and key results. So it is best to email the Rural Health Transformation Program generic website, which can be found on an email link, which can be found on our website. And I personally look at those and we'll get a response back to you.
That's great. And I put a link to the
you.
website in the chat here, and we will make sure that that goes out in our follow-up materials too. So Tom, thank you for sharing in a criminally short amount of time.
Sure.
That was really impressive. I want to turn though to Dr. Stack and ask a little bit about some more recent events in our nation, particularly around funding freezes. Folks may remember this a little more from last year when there was some chaotic questions about what was and wasn't being funded. More recently, 5 states had their funding temporarily frozen for various issues. And then in the last week, Minnesota's Medicaid funding was frozen on some allegations around fraud. Dr. Stack, I know folks are hearing a lot in the news nationally. I was hoping maybe you could share a little bit about where we stand as a state right now.
Thanks, Dustin. So last year was arguably one of the most tumultuous times we've had in federal state funding partnerships, probably in anyone's living memory, I think. There was a lot of uncertainty with grants being canceled precipitously, being canceled with notices that were sent, and you were told that as of yesterday, the day before you received the notice, that you couldn't incur any additional expenses. It was chaotic is a kind word for it. And a number of nonprofits were ensnarled in that because they had to live with the very real uncertainty that they may not be able to meet payroll or meet other expenses and obligations that they'd made in good faith. I feel we're very fortunate. Governor Beshear has litigated multiple times now with other states. And because of his efforts and those of the other states who joined in those legal actions, the funding has been preserved for the most part for Kentucky. Other states who have not become party to those litigation efforts have had their funding stop and have done things like had reductions in force and ended contracts. And I suspect some of you may have friends or colleagues who do similar work to you in other states who have perhaps shared those stories themselves. So at the moment, we seem to be only in a relative sense somewhat stable, with the exception of Homeland Security at the federal level, which is now the subject of a very limited government shutdown. All the other major agencies have been funded through the end of the federal fiscal year. And so we should be good, at least through the end of September 30th, with what Congress has appropriated. The executive branch at the federal level has taken it upon itself on a number of occasions to exercise its own independent judgment in ways we've not really previously seen, and certainly not at this scale, and make other decisions, and substituted their choices for the appropriations the feds have done through the legislature. So we're going to have to be hopeful that we don't see too much more of that this year, and that we can at least have a period of stability through September 30th. With regard to our Medicaid program, with regard to childcare, those funding sources have not been stopped or disrupted for the Commonwealth of Kentucky. We believe we are in compliance with all the requirements that are asked of us federally. And so we are not aware of any unique risk to our state that would be any different than any other state might face. So for right now, the best I can say to all of you is continue doing the wonderful work you're doing. We will continue to support you and fulfill our contracts so long as the federal funding that backs them continues to come along as it is supposed to, and as we feel we are obligated to receive under our agreements with the federal government. And folks, let's just keep on doing the very best we can. There's a lot of folks in Kentucky who rely on each and every one of you and all of us to make sure that they get services and supports so central to their lives. So just an expression of gratitude to each of you for what you do. And Dustin, does that address this particular portion?
I think so. Yeah. I mean, in the midst of a really difficult environment, I think you are doing an incredible job, and it's good to hear that both the funding is continuing and we have leadership that's willing to stand up and push back when bad decisions are made. Speaking of funding, we are also in the middle of a process of developing our biennial budget within the General Assembly. There's a lot of discussion going on right now in Frankfurt about what we need to do to be able to fund the work of the Commonwealth for the next 2 years. And CHFS has an outsized role in our state budget. I was wondering if you could share a little bit about maybe the governor's proposal and then where we see some contrast with what the House has currently as it continues to move through with the Senate and then finally a free conference committee.
Sure. Thank you, Dustin. So look, the budget is a very, very important exercise for the state every 2 years. Not everybody gets everything they want. That's the way it has always been. A number of folks, though, have not been involved in this process since before 2020, and any of who have not really had a difficult budget until this year. COVID presented all sorts of other challenges, but one thing it did not challenge us with is once we really got into the swing of it, there was a lot of extra resources and funding that came through. Now we're going to face the real difficulty is that enormous tsunami of extra federal funding that came in is now gone. It has all been used up or depleted, and if there's anything left, it is just the very faint whispers of a tiniest amount. And so in the next budget, there won't be any of that left. And so the tide has gone out, and so now we're going to have to return to what was more normal, but that's now having to look back since before 2020 for people to know what that normal looked like. At the same time, for state funding, the state is facing less, income tax receipts because of the reductions in income tax year over year. And as a result of that causes smaller growth in our income for the whole state, for the general fund, which we rely on. And as a result of that, the legislature is going to have to make choices to live within that budget stream or that revenue stream, which is now less than it might otherwise have been were we not decreasing the state income tax. As a result of that, this budget is going to be the first difficult one that many people have lived through. Some legislators and certainly many younger folks who have not been through the budget process in a nonprofit or doing the work you do. Your advocacy these next 2 weeks to the Senate in particular, but the House as well, because at the end they're going to both have to agree to a final budget, is essential. In the House proposed budget, House Bill 500, and there is a committee sub for that passed through the House, they proposed 4% reductions across the board to our base funding in the first of the 2 years in the next 2-year budget, and then 7% total, so another 3% in the next year. Those are draconian cuts, folks. None of the groups we work with will be spared if we go through that. If that is what were to happen, we would have to starkly reduce certain contracts, perhaps eliminate others, and reduce payments to a variety of different service providers. It will not be pretty. The governor's proposed budget fully funded Medicaid for the next 2 years. so that we allowed for maintenance of it and the growth that would need to happen just from inflation and all. Also provided additional resources for our Department for Community-Based Services, for our Department of Behavioral Health, Developmental, Intellectual Disabilities, and maintained funding for other key areas. Now, one of the challenges, and I'd encourage anyone here who is an advocate or who may come to Frankfurt to advocate on these topics, one of the things that gets hard if you're not on the inside, and by that I mean a legislator working directly with legislative staff or an executive branch leader working directly with our staff, is these things are very big and complex, right? And so the governor's proposed budget had a number of additional initiatives in there: relief for rural hospitals, energy assistance supports, assistance for folks on the health benefits exchange who find themselves with incredibly steep increases in premiums and are uninsured because they couldn't afford those premium increases. When you put it all together, the governor made an assortment of choices, difficult choices, but the whole package provided a resource base that, in his best good faith assessment, met the needs of Kentuckians, at least to the best of his ability with the resources available. That doesn't mean everybody got everything they wanted. It doesn't mean everybody got everything they thought they needed either, even in the governor's budget. But his budget, I think, was very appropriate and aggressive, trying to make sure we maximize the services and supports we provide to Kentuckians across a wide array of things, including not just health and human services programs that I have a role in, but pre-K for all, universal pre-K, and also probably other investments in other major programmatic areas. The House budget stripped all those additional budget requests away, all those additional proposals away, then added cuts. And so now we're having to build back. So now the action is in the Senate. It's, as I understand it, anticipated that the Senate will probably drop its version of a budget bill this week, and there will be discussion. So your advocacy is really, really important. Folks, I would encourage you not to go and try to earmark just your group. I don't know what we'll do if a bunch of people go in there and get like, well, protect us, protect us, protect us. Either we're going to have to, I don't know what we'll do, but we're going to have to cut if we have big drops. So saying that we have the money to pay things when we don't have the money to pay things doesn't change the fact that we don't have the money to pay things. I would ask you, and I'll wrap up on this and then see what questions Dustin has. We are with you, folks. I mean, the staff who work here care deeply about these programs. They care about you and the work you do. They care about the populations we serve and support. We sometimes become the messengers for very difficult messages we'd rather not have to deliver. I just ask you to please keep that in mind. You need to advocate. You need to advocate to both branches of government. We accept that and we support you in your advocacy. It's very, very valuable. Please know, though, we're not doing these difficult choices if we end up having to do them because we want to. It's because we have to live within the budget that we are given. So, Dustin, what other questions do you have?
Yeah, I have a couple, but I do want to reiterate that, the 4% and 7% reductions to the base budget are sort of an initial step that the House took. In addition to that, they required a 2% increase in pay, plus a 24% increase in health insurance costs for employees. Then with programs like DCBS, they added these different priorities that they said, should be included in what we are appropriating for you, but that squeezes everything else out. So I just really want to echo what you said, which is that if folks are going to push for a better budget, they need to push for a better budget overall. And one other thing I want to add is that there is about $600 million unspent in the total budget that the House proposed. So it's not like they budgeted to the last dime. They have enough cushion to continue to improve on these investments. So as folks are engaging with the Senate, please make sure that we're engaging a whole picture, and like Dr. Stack said, not trying to carve out certain issues. One thing we didn't mention is what they've done with Medicaid. There's a lot of folks on the call who are very engaged with Medicaid, who work with Medicaid, who advocate for Medicaid, and that's another area where there was a significant shorting from the General Assembly. Correct?
Yeah. So in House Bill 2, the committee sub, it appears that there's a reduction of $600 million in year one and about another 900 plus million in year two. It's between 1.5 to 1.6 billion with a B dollars, which is a big reduction. And there are some things we can't reduce. We're not allowed to. So like we are required to pay for all services, that are necessary medically for children. And so we have over half the children in the state are on Medicaid. We are required to do cost settlement with certain other providers or for FQHCs to rely on a fee schedule that's established by the feds. So things we can't cut mean that the things we can cut, the things we are not allowed to touch, mean that the things we can touch get steeper cuts still to make up something that big. It's really, really hard to know what we would do because the options are so unpleasant and terrible to consider at times that we'll kind of really have to see what the budget comes out as and then make really, really hard choices. So all the Medicaid beneficiaries will feel that. In addition to House Bill 2, which is not the budget bill, but where people should actually be very actively engaged because there are co-payments that are proposed in a more accelerated timeline, verifications or re-verifications of eligibility on an earlier and more aggressive scope. There's a number of things that House Bill 2 accelerates and would make Medicaid even more difficult for people to benefit from and access. So both House Bill 2 and House Bill 500 should be things that this community hopefully is very actively engaged advocating improvements in.
Yeah, this time last year, we were sounding the alarm about the One Big Beautiful Bill Act, which was itself a draconian cut to Medicaid. House Bill 2 and House Bill 500 go much further than that. And there were already some of those cuts factored into assumptions in the governor's proposal, and then the House, undercut that by even more. So that is definitely true. One last thing I wanted to ask about is just that, a lot of these programs that are proposed by the General Assembly, like House Bill 2, have an additional cost associated with them, even though those costs are not factored into the budget. And so while the legislature doesn't like to talk about that much, the governor has created a website called the Facts and Fiscal Notes page, where he tries to, explain what some of these additional costs, usually administrative costs, would be. Is there anything from that page that you want to highlight as we kind of move toward the end of session here? And I'll put a link in the chat for folks as we kind of wrap up this section.
Well, thanks. Well, I'd encourage anyone who is, your reliance upon these funding sources, either for your nonprofit, your programs, or the people you are serving and advocating for, I'd encourage you to take a look there and see. The governor started doing that a number of sessions ago because there were instances where folks said, well, we weren't told it was going to cost more. And so this is an attempt to try to say, no, we're going to make sure everybody knows what we think it might cost. In House Bill 2, there are extra cost increases because of IT costs that would be elevated because of extra things we'd have to do. Also, some of the changes to the managed care organization structure will drive up costs that they charge the state because of the extra work they have to do and other aspects of it. So I'd encourage you to take a look at that. There are some letters that we have sent out as a matter of form. They're all signed by me when they come from this cabinet. But we have letters out there that are commenting on things like House Bill 500, House Bill 2, and others that we send to members of the legislature so that the administration is on record where we have concerns. And hopefully that's been helpful. I've seen members of the General Assembly with those in hand. So at least we know that they're being received and that some of them are actually reading them. And then, of course, they'll have to make their own determination of how they use that to inform their choices.
Secretary Stack, I really appreciate your time and insights here, and I really hope people take your advice and engage with their legislators as we move here toward the end of session.
Well, Dustin, I'll end with this and just say, first of all, thank you for the opportunity to be here. Thanks to all of you for the work you do in your advocacy. Things will get more challenging as we go forward because the big bolus of funding that came from COVID is now not here. But remember, this cabinet touches every Kentuckian one way or another, whether it's through nutrition support with SNAP, health insurance coverage through Medicaid, social services we do with community-based services, behavioral health for folks who are some of the most in need of our help and supports, aging, independent living communities, and so many more. So no matter what happens, I'm confident that we'll all still come together, rely on each other, and try to do the best we can so every Kentuckian can reach their full potential and thrive.
Hear, hear. Well, thank you, sir.
Thank you.
While we've already kind of started the conversation around Medicaid, I'm going to hand it over to my friend Priscilla to keep that conversation going.
Thanks, Dustin. And I am excited to transition a little bit more into health updates. The last time that we talked was in November, where we were sort of waiting. We were just about to go into open enrollment. We're still just a couple of months into child renewals happening, and a couple of other big health updates on the eligibility and enrollment side. And so with that, I'm really excited to invite David Very, the Assistant Director of Health, the Division of Health Plan Oversight. Yes, there he is. Hi, David.
My camera is working. Good morning. Good afternoon.
Perfect. Glad that that worked out. So David, I really just want to open up the floor and give you the opportunity to share some updates. We can just jump in.
Super. I'll start with the kiddos because it's always, in my vision, one of the more important populations. Since we began the renewal process of having to renew Medicaid again after the pandemic, we have successfully renewed 353,000 some change children across the Commonwealth in Medicaid, and a whopping 87% of those are successful, which is fantastic. We still want to go over the 13%, as we want 50,000. If you're one of them or a parent of one of them, that's important. But this shows that our efforts are working. Typical with the rest of the Medicaid population, by far the number one reason that people are not being rolled over to Medicaid again and renewing is not getting your information in. The administrative termination or procedural termination versus not being actually eligible, which is a crying shame. That means there are many of those persons who are eligible. They just don't know it or didn't get the right form at the right time. So that continues to be our mission there, is to try to get that word out and make sure that failure to return verification it's always probably going to be the number one reason, but hopefully it'll be lesser, because we really want to get that word out. And as Dr. Stacks said, over half of our children in this Commonwealth get their health coverage through CHFS or Medicaid, and that's a good thing. It's good coverage, and it keeps providers paid and keeps children healthy. And with healthy children, parents are more likely to go to work or be healthy themselves. So that's the good news, but still have work to do. As far as customer feedback or that kind of thing, we do run a survey of Medicaid renewals to see from the beneficiaries, how is it going? And voluntary, of course, and with voluntary surveys, you can kind of get a little bit of everything, but it's consistently strong feedback, meaning positive or at least neutral. Depending on where you want to draw the line, 20% and upwards are at least neutral, with 40% or more being positive or somewhat positive. Which, given that we're a government program, I'll take it. The problems that are identified are the ones I think we all know of: problems with the platform, problems with uploading, looping, systems kind of issues. Still reported that the Connect online portal is the number one way that people do interact with us, but is also the number one complaint driver. So I visit other websites on my free time. I know that we are still progressing and we're still listening and trying to get the best solution. I said that at all in one breath, Priscilla. Where can I go next?
Yeah, I appreciate that. So a really quick question before we move on. You said for the call center, about 20%, like it's positive, or 20 to 40% positive or neutral?
Yeah, this is renewal satisfaction surveys. So it's from anyone being renewed, not specific to the call center,
Okay.
or TCBS or anyone else. And let's see what it is. 38 to 50% are either very satisfied or satisfied.
Okay.
So around 60 to 70% are in that kind of bucket. And then 10 to 20 are either neutral or dissatisfied.
Okay. And
So
that's
depending how you want to slice that.
yeah, that's still pretty solid. And those renewal surveys, they go out like through the mail or
I think it's both through the mail and online.
okay. And that goes out to everyone who's had a renewal and
Yeah.
then they respond. Okay.
Yeah.
Perfect. All right, that's super helpful context. Just to understand who else.
Yeah, still voluntary, and it's not going to get to everybody. It's still a relatively small response rate. I think it's in the 5 or 6% range, depending on the month.
Okay. That is solid.
And speaking of month-to-month trends on our renewals, it's about the same. We're seeing the same types of reasons that people are not returning their documents or getting terminated because of that. And so nothing that we can identify at this point that, wow, we're already into the third quarter coming up, that shows something out of the ordinary from since when we began the renewal process again.
Okay, that's really helpful. And are there any trends that you've noticed, feel free, but any trends that you've noticed with, if you compare like adults of the children population, like areas of the state or demographics or anything that's like sort of standing out, no, not to put you under the spotlight.
Well, nope. This is going to be a short answer, but an honest one. We're putting a tack in that and circling back. The raw data that we get does not really make that comparison very well. And so I'm having some special data pulled or some analysts of it. So we will get back with you about a comparison of children renewal activity versus adult renewal activity and try to put some metrics on that. So apologize for the delay.
No worries. I'm glad that you all are like digging in and looking into that. I know that there are a lot of lessons learned from the adult unwinding,
Yep.
now in 2023. Oh my God, that's weird to say. But that started almost 3 years ago. And I know there have been lots of system changes and things like that since then. So just wondering if you all had been tracking any of that, but I appreciate that you are working on that. That's wonderful news. All right, let's feel free if anyone has any questions about any of that, please hop in the chat. But let's go ahead and transition into open enrollment. Can you give us a recap what this past open enrollment looked like? I know the last time that we talked was before those enhanced premium tax credits expired.
Yep.
So let's give everyone an update, and then what did open enrollment look like for Kentucky this year?
Yeah, open enrollment, I'm going to call it less bad. We were expecting or bracing for something worse than kind of what we saw. We did see around 89,000 people who enrolled in a qualified health plan marketplace plan for 2027, 89,028 or something like that, which is good. It's 8% lower than last year's near record of 97,000, but still not much higher, slightly higher than any year we were at healthcare.gov before the pandemic, to kind of level set that, put that in perspective. We did see the two groups that were kind of targeted most harshly were the people who were making more than 400% of the federal poverty level or no longer eligible for tax credits, and immigrants who are below 100%. That sounds weird that you don't qualify because you make too little, and then are denied Medicaid because of their immigration status. Take the 5-year bar, and those persons were also not eligible for tax credits. We saw all of them not enroll. It was extremely rare that we saw groups that we could identify were in either of those two buckets of persons, groups of people who enrolled. They just simply probably are uninsured.
And for both groups, they would be eligible for like to buy a full price plan and that's it.
Yes.
Yeah.
A full price plan, and then with the premiums going up across the board and deductibles shooting through the roof, to be honest, it makes that choice very difficult. Only the sickest people, unfortunately, are choosing that option. So we started out 8% off of where we were at the open enrollment of last year. The enhanced tax credits sunsetting were brutal. What was equally as brutal in some ways was instead of 120 days to turn in documents for income verification, because of the federal rule change, people were only given 90. And that clock started for a lot of individuals in mid-October, early November, because of the passive renewal. So that means that we have seen churn with persons trying to verify and losing their tax subsidies and having to put it back on, unlike, to be honest, anything I've ever seen, as people are just scrambling to fix that problem. We're trying to re-up and redo our efforts to get the word out that no, you really have to get this document in and simplify that. But it still was and continues to be a challenge. All that in aggregate has meant that since our starting of 89,000 and change, the first month after open enrollment, we lost 1,500 enrollments, and it dropped down to 87,000 and change. Then the second month, between February and now, we've lost 3,000 more. So we're now a full 14% below of what we were last year at this time. It's still hard to see, hard to tell whether this is, is it going to keep on going down to the bottom? We don't know. We hope not. But anecdotally, we don't have a system change is coming, but we're not capturing the reason why people are disenrolling from them. We can look if they've been terminated for non-pay, but that gets a little bit muddy because it could be that they're just renewing or changing plans, or there's a problem with the verification. So it's hard to really tell in the fog of war as it is to know what we're seeing. But we are seeing more terminations than we have compared to years previous.
Or you said it's about 1,500 in the first month and 3,000 more between February and now. For those roughly 4,500, are most of those, is it a mixed bag of folks like canceling or terminating, or like and that failure to verify, folks losing?
Yeah.
Okay.
It's mixed bag. People have been terminated for non-pay or lost their verification and their tax credit and just say they don't want to deal with it anymore, or just your regular churn.
Yeah.
They could be going to employer sponsored coverage or junk plans or something like that. The other thing that is very unfortunate is that we received more requests for exceptional special enrollment. This is where you're not a life qualifying life event like having a baby or losing your coverage, but something else. Almost always it's I didn't sign up, I didn't want to, I got involved in a health sharing ministry or something like that. And we've seen more of those. We saw more of those in the first month than we did in almost 2 quarters of last year.
Wow.
So we're already seeing the effects of the junk plans or people just trying to wing it, or maybe I don't need this, or the deductible is too high. And now they're coming to us saying, now I'm sick, now I need some help.
Yeah. And just as a reminder for folks, if they say lost their coverage because of failure to verify, what can they do to remedy that?
For failure to verify, you mean like they were enrolled with Connect and they forgot to turn their verification in?
Yes,
or
especially, yeah.
There'll be a 90-day grace where we can just put the tax credit back in, and it's abrasive, but there's a fix for that. What we cannot do is if you were legitimately terminated for non-payment, you're given 3 warnings on 3 different months. Then that's up to the issuer, and they are always saying no to that.
Yeah. And then for folks who they missed open enrollment, they don't have a special enrollment period, they reach out through an exceptional special circumstance. It sounds like you guys evaluate those case by case.
We do, unfortunately, now that we're 60 days past the open enrollment, it takes away a lot of our regulatory capabilities.
Right.
There is a special enrollment reason that's untimely notice or reasonably unaware. Yeah, it really is that vague, even in the federal regulation, but you can only use that within 60 days of what they are saying they didn't know about. So we're even losing that capability going forward and entering the hard part of the late spring and the early summer.
Yeah. And you would recommend, for a client who might find themselves in a position where they need coverage, they're not sure if they're eligible for a special enrollment period or an exceptional special enrollment, you would still recommend reaching out to a connector, send it to the inbox anyway, and you all will decide and communicate, for them. It's better to
even though
reach
it
out.
Creates more work. We would rather do the work, and maybe we can find something that they didn't see, that they didn't know about. Many times, not many anymore, but sometimes that is true, that we find something else in their case that they didn't know about.
Fair. So always still encourage folks to reach out if they need help. Find a connector. Connector can help bridge that gap for folks and walk them through that process. But don't self-select out. Just still go ahead and send in a case. Reach out for help if you're in that situation. Okay, one last question, maybe two, if time permits. But there's always, right now, March to April, there is always a big transition in the federal poverty level in the system from the 2025 number to 2026. What does that mean for folks who are enrolled in Medicaid or who are enrolled in a marketplace plan and might be right on that edge? What can folks expect there?
For people who are enrolled in Medicaid now, nothing. That is going up above them and they need to take no action. It'll be invisible to them. For people applying for Medicaid, good news. Whatever the minimum rate or minimum level was, it's $1,800 for a single person right now. It's going to be higher beginning April 1st. So that's good. If you are enrolled in the marketplace and you're right on the border, that means, because that's based on the federal tax year last year, that means the federal poverty levels that's going to raise above you, and you are going to become Medicaid eligible. We sent out a notice Friday. So check your mailboxes to anyone that's in that good predicament, because what's going to happen is we are going to automatically enroll them in Medicaid and disenroll them from their marketplace because it's better benefit. About 2,000 people this year, a little bit lower than in years past. That has a lot to do with the macroeconomics of what's going on out there, that way above my pay grade. But we give them notice and then switch them over. We are, I believe, the only state in the union, only one of two that does this. But it means that 2,315 people are not going to have to pay premiums and not going to have to pay copays anymore as we move them to Medicaid.
Yeah, shout out to Connect and Kentucky for doing that automatically. Love that. And so consumers can look for those notices in the mail if their eligibility is changed. All of that happens automatically, and they're informed of that ahead of time.
And an innovation that we brought online for the 400% problem with people having to look at that FPL also works now, where connectors and agents were able to see some kind of reconnaissance of people who are right on the edge. We kind of just work with that on the ones and twos basis of retail level. This is going to happen, right? Because sometimes people actually underestimate their income, which is strange to me, but it happens.
Well, and this is an especially important year for folks who are right at that 400% line. If they're going to be over, the threshold or the repayment cap has been removed. So if folks are over that 400% line this year, they'll have to pay back the entire premium tax credit. Is that right?
That is correct. Unlike the 100% threshold, where if we were to estimate, we being an exchange marketplace, were to estimate your income as being above that, then you fall below, you're not penalized. For the 400%, it's in the tax code, there is no grace. So if someone makes 450% of federal poverty level, think $97,000, $92,000, excuse me, for an individual instead of 83. So we're still talking, well, that seems like it's a lot. Well, it is. But if they were buying their insurance through us and getting $1,000 a month tax credits.
Oh, no.
Priscilla, oh, there you
Okay, sorry. I wasn't sure if I froze or if it was David.
go.
All
I think
right.
it was David in this case.
Oh, I can hear you.
Okay, I can hear you too. All right.
Okay,
Thanks. So,
apologies.
no
It was
worries.
just about that time too, but anything else? Yeah.
No, I think we're just at time. Just want to thank you for your time, and a friendly reminder for folks. Make sure if you're working with clients, just because of all the changes, this is a great year. Make sure you're working with connectors, know who they are in your community, refer folks to those to connectors in your community, and make sure that folks' income is accurate in the system, because this would be because the risk, if they're especially if they're close to 400%, they could have to pay back quite a bit of money for their premium tax credits, and we don't want that. So if you know folks who are having any problems or need any help, always reach out to KHBE, the wonderful folks over there, or connectors who can help walk clients through all of the complications that can come when in real life cases and circumstances.
And also the immigration rules for Medicaid have not changed. There are no work requirements currently, and Medicaid is still based on your monthly income. So if someone loses their job, if transition life happens, get that application in, get enrolled in Medicaid to protect yourself and your family. The changes of HR 1 or House Bill 2 have not happened yet. So it is business as usual.
Perfect. That's a perfect note to end on. Thank you so much for your time today, David. And
Thank
if
you
folks
for
have
inviting me, Priscilla.
yeah, and if folks have any questions, we'll be in the chat. And with that, I will turn it over to Jessica.
Hi, and thank you so much, Priscilla. Hi, I'm Jessica Klein. I'm a Senior Policy Associate with the Kentucky Center for Economic Policy, and I'm joined today with Roger McCann, the Director of Division of Family Support, to talk about the Supplemental Nutrition Assistance Program, SNAP. And Roger, there you
Hello,
go.
Jessica.
Yep, good to see you.
Good to see you.
I was hoping first we could talk a little bit about the counterproductive work reporting requirements in SNAP that were recently expanded by HR 1, the One Big Beautiful Bill Act. I think in the past we've kind of described these and how they've expanded. So it's now people 18 to 64 who have no disabilities and no children under 14 in their home. And they must report at least 20 hours of working per week, paid or unpaid, or participation in the employment and training program. And otherwise, they are only eligible to receive 3 months within a 36-month period. And I was wondering if you today could talk a little bit about the exemptions from that as people start to complete their work reporting and are trying to adhere to this expanded requirement. If there was more you could tell us about the exemptions from the program.
Sure. Well, and just to keep in mind that HR 1, it did change that the age from 54 to 64, but it also eliminated some exemptions for some folks. So those folks who are unhoused or homeless, as the language that they use, veterans, and individuals aging out of foster care up to 24 years old. So those folks were exempt before, so they are now included in that. The other big thing that happened in Kentucky, and a lot of other states that I've talked with weren't affected by this. You know, we have lots of counties, and we had 117 that we were able to get an exemption for because they met that criteria where they did not. We were able to demonstrate that they did not have enough employment in that region to be able to for everybody in that county to have a job. And so there were two exemptions. One is if the region had above 10% of unemployment for a period of time, and if they didn't have enough jobs. HR1 eliminated that piece about not having enough employment in that region. That meant that we had to go back and look at all the counties. Now, we did receive a letter from USDA, and they terminated our waivers for all those counties a month early back to October 1. They would normally have expired October 31st, December 31st. December 1st would have been the date that they would have normally expired, and they expired early, 1 month early. The I won't say good news. Good news is that we were able to then go back and demonstrate that 5 counties still met that criteria of the 10% unemployment. That's not necessarily good news because it means those counties have really got some bad unemployment in those counties. But those were approved by the USDA, so we were able to get those 5 counties waived. Elliott, Lewis, Magoffin, Martin, and Wolfe counties, we have those exemptions reinstated. The other thing that happened is that the HR1 went into effect November 1. And so for a lot of folks, they didn't know that they were losing that exemption. They didn't understand the exemption. And so that's been a concern. What's the impact going to be? We did have a government shutdown in October and November, and states were granted an allowance, a waiver for the month of November. So that time limited, you mentioned the 3 months and 36-month period. We received a letter from the USDA. We did not have to count those folks in November. So normally at this time, we would have seen that impact hitting for those folks. Because we don't count the November, we were able to go into our system, take that month away, and notify them that they did not have to have that month counted against them. So that delays the impact a little bit. So we've gotten a lot of questions about how many folks were going to be impacted. What's that look like? Because we're delayed a little bit right now. We're a month behind, which is good for those folks. But we're still analyzing what that impact looks like. I can tell you that in November, we had 17,000 folks who would have gotten a bad month, and we sent them notification. It doesn't mean that they had the 3 months, that's just the 1 month, but that we were able to notify them that they would not have November counted against them. So that delays it a little bit, and we're going to be analyzing that data here now that the month of February is wrapped up, and hopefully we can get some kind of an idea what the impact of that looks like. But those are in effect. We're still doing some work around making sure that folks are aware of that, and we need you all to help us spread the word about that the work requirements, because for those 117 counties, they were not used to doing that, and now, of course, the age from 54 to 64, that group of folks didn't know about it either, and they have not been used to that in Kentucky.
Great. Thank you so much for going through that. And I know folks can go onto the cabinet's website to read more about those exemptions and see if they're one of those counties that have been waived, and learn more about the SNAP employment and training program as well as an opportunity to reach some of those requirements. Did you want to explain what the employment and training program is for folks that are unaware?
I would love to. So there's a couple different programs out there, and it gets weird and confusing because they all use kind of the same terminology. There is a SNAP employment and training program. Now, talking with the USDA, and we talk about the ABODs and the work requirements, USDA says that they have 2 major priorities right now. One of those is the food restriction waivers that states are filing across the country. And there's quite a few states now that have done that. And then the other piece that they're really interested in is work requirements around SNAP. So those are the two priorities. A big component of that work requirement is the SNAP Employment and Training Program. So SNAP Employment and Training has nothing to do with nutrition, has nothing to do with food. It is completely a funding stream for workforce training. And so the best way, the easiest way I can describe it is that SNAP Employment and Training is a rebate. I liken it to if you've ever bought something like a refrigerator and they say, well, you get a $100 rebate. If you have the right model and you buy it in the right time frame and you find that paperwork and that receipt and you fill out all the paperwork and you send it in on time, you might get your $100 rebate. It's kind of like that. What has to happen is that an organization, they have to be a SNAP Employment and Training approved provider of that education. They have to offer the right training classes, and they have to offer it to people who receive SNAP, but that are enrolled in the SNAP Employment Training Program. So like the rebate, you have to jump through some hoops. But if you do all those things and you provide employment and training, if you provide a job skill training, the USDA, if you can demonstrate that that person was receiving SNAP, will reimburse you 50% of the education training costs. Well, that's a pretty good deal. If so you cannot use federal funds. It has to be state or private funding. And then the USDA will basically double your money. So this is a good thing. The intent is, of course, that you are helping folks who are in need of SNAP find a better job, maybe increase their income, and use that to address the food insecurity that they were facing. So SNAP Employment and Training is a workforce program. It is a rebate program to rebate the cost of training for folks who are utilizing SNAP. Where things get interesting is that there's also a SNAP education program. Now, SNAP education is a nutrition program. It is all about cooking classes. It's about selecting the right healthy foods, how to select them, how to prepare them, how to consume them, and do so on a budget. That program, the SNAP education program, was eliminated by HR 1. So states are now spending that money down. In Kentucky, we are wrapping that program up, probably run through the spring and the summer. That is under contract with the University of Kentucky. It's operated through the county extension offices, and basically it is cooking classes. It is teaching people how to eat healthy. But that was eliminated. So SNAP Employment Training is a workforce program. SNAP Education is a nutrition program. To throw a little bit more confusion in there, there is also a education and training program that is under the Child Nutrition Act that is targeted for schools. So there is SNAP Education, SNAP Employment and Training, and then a nutrition education and training program that is under the Child Nutrition Program. All this creates a lot of confusion, and it is very, very easy to get the words switched up, and it happens often. But that is it in a nutshell.
Well, thank you so much for covering that, Roger. And we did include a link to employment and training website in the chat as well, so people can follow up there if they're confused by all the programs that we covered today.
Sure.
I did want to deviate for a minute from our regular agenda to talk a little bit about Senate Bill 257, which will be heard in Senate Families and Children's tomorrow morning. And what we know about this bill is that it would do a couple of things that would impact SNAP significantly. The first is eliminating our broad-based categorical eligibility in the program, which changes both the gross income limit and creates an asset test for the program. This is something that's been proposed before. In the past, it would have cost $2.4 million annually to implement and requires a lot of staff support to do this additional work of an asset test. The second component is that it significantly dials up an already stringent verification process to potentially a monthly verification process with lots of different conflicting databases, which we worry might have an impact on our error rate, which would impact the cost of SNAP for Kentucky. So those are some of our concerns about SB 257. And I was wondering if you could tell us a little bit about that verification process and what some of these changes might mean for the administration of the program.
Well, I think you've said it already. All of those things drive cost. So putting aside the impact that it has on Kentuckians, right? Well, first up, all these things puts more burden on Kentuckians. If a Kentuckian is eligible, and then they're also eligible through a categorical eligibility, it's typically a lot easier, faster for them to receive a benefit through that means. Eliminating that doesn't mean that they will no longer be participating in the program. They may just have to go through a lot more hoops to do that. So it puts more pressure on folks who are simply trying to feed their families. The other thing though is that all of this creates more administrative burden on the program. If you have a program that you certify once a year and you double that to every 6 months, you just doubled your cost. If you do it 4 times a year, you just quadrupled your cost. If you do it 12 times every month, you just, I don't even know what the word for that is, a dozen. And so you're creating a situation where folks are trying to get benefits. They're burdened by having to recertify more often. But if they are having to come into an office, or even if they're faxing in things or sending in things, you've got a staff person who has to do that work. That increases staff costs. That increases the volume and number of folks that have to be there to respond to that and do that processing. So yes, that would increase the administrative cost. Also, every time that you're updating that record, there's a chance that something goes slightly wrong, and slightly wrong can drive that payment error rate. And the payment error rate, if it goes above 6%, is suddenly in the $50 to $60 million range in Kentucky. Or if it goes above the 8% mark, we're looking at over 100 million a year that Kentucky would have to match. So again, you have this risk of driving cost. And so that, first is the burden it places on Kentuckians, but secondly, it's that cost. And that cost on October 1 will be 75% of that cost will be coming straight out of the Kentucky General Fund. States have to match SNAP admin at 75% starting October 1. So, those are all, as you said, very big concerns when you look at something like that. Anything that would increase the cost of operating the program will be detrimental.
Thank you for covering that. And I think we've been happy to see the administrative cost included in the second version of the House budget, and hope that that makes it through the full budget process. And I know that we have not accounted for SB 257 in that cost. So thank you for covering that. To end us on a brighter note, I was wondering if you could talk a little bit about the summer EBT program, which we know provides $120 per child in grocery money for families with school-aged children. And that's vital in Kentucky, where we have 1 in 5 kids who are food insecure. So could you talk a little bit about the summer for summer 2026?
Sure. So this will be our 3rd year in operation. Kentucky was one of the first to implement. We're looking forward to doing that again this year. Yes, it's $120 per student. And it is designed to try to help offset folks' budget. If you've ever had kids and they come home during the summer, they eat everything you have. They're not receiving that school lunch, for example. So that $120 goes quite a long way in the summer months to try to offset that. We do intend to operate the summer EBT program. We are currently waiting on the final plan approval. So we are checking the mailbox every day, but we haven't gotten that yet. We do expect to receive it, and we've got all of our plans laid. So that includes a initial allocation onto summer EBT cards somewhere around mid-May. And so that's what we'll be looking at. But we are, like you say, happy to be able to operate this program again. Helped a lot of folks the last 2 years, and hope to keep doing it for the future.
Thank you, Roger. And I do see a question for you in the chat, a follow up on 257. So I know the cabinet has really been touted and thanked for all of its work to keep our error rate low. So the basic question is, would it make it easier or harder to keep our error rate below that threshold for that cost share?
So I'm just reading that. Let's see. With 257, so if 257 increases the number of times that a person would have to verify or to recertify their information, that means potentially that, depending on what that process is, you're re-entering, you're recollecting, you're recalculating eligibility or benefit. Every time you do that, there is always a risk that something goes wrong. So if you increase the number of times that would happen, I would think that it would increase the risk that your payment error rate would go up. So my understanding is that 257 would seek to do that. I would be concerned very much about the risk of increasing payment errors, just simply because of the amount of churn that it would create. Also, that's putting more pressure on staff, and the volume of work that's required. And so, you see those pressures as well. So.
Great. Thank you so much.
Thank you.
Well, I think that covers everything for the SNAP program. And with that, I'll turn it over to my colleague, Dr. Sheila Schuster.
Thank you very much, Jessica. Made me hungry to hear you all talking about that. So I'm Sheila Schuster. I'm a psychologist. I run the Advocacy Action Network, which is the Kentucky Mental Health Coalition, and then the 874K Disabilities Coalition. And we have some really exciting Medicaid waiver updates. And I will start by calling on Tanya Dickinson, who is with the Department for Behavioral Health, Developmental, and Intellectual Disabilities, to tell us about what I think is the most exciting waiver or state plan amendment, but it's acting like a waiver because it addresses the needs of people with severe mental illness. So Tanya, can you give us an update, please, on the 1915I SPA?
I can. I'll go quickly. Thank you for the opportunity. Always glad to see folks and share about this program. I'm Tanya Dickinson with the 1915I RISE implementation program, and I think most everybody on this call is aware of the program, but just the quick high points. It's a new Medicaid benefit under Kentucky's 1915I state plan. It's designed for Medicaid eligible adults 18 and over with serious mental illness, with or without a co-occurring substance use disorder, and brings 10 essential home and community-based support services to participants in their community. And those range from everything from in-home support services, supported education, employment, supervised residential, case management, and just a wide variety of things to keep that individual successful and in the community where before they may have had challenges with hospitalizations or other issues related to their illness. Slide. We're really pleased with the progress of implementation so far. We want it to be faster, of course, but here we are, and we want to do it right too. We are excited to share that we're now operating and taking participant referrals in 10 community mental health center regions, and that is the regions themselves, not necessarily the community mental health center itself. But Pennyroyal in the east, 7 counties around the Louisville area, Kentucky River in the southeast, and I think I said Pennyroyal was in the east, but it's in the west. If I did, I apologize.
Right, Hopkinsville.
And New Vista, which is around the Lexington area. You can go see all of our providers at the department's provider directory once they have completed their Medicaid enrollment, and instructions for referring participants to the 1959 RISE program can be found at the link there. And this is all on our website, and I'll also put all these links for resources in the chat before we go. Slide, please. And for those of us like me who are challenged with our East and West, this is the counties that are now being served by 1915 RISE. We expect additional regions to come on in the near future. And the way we bring on each region is once all of the 10 available services are available within that region, then we begin accepting participant referrals from that region. And providers can be statewide, local, regional, just any of a wide variety of things like that. We're always looking to recruit more providers, of course. I think SCL and Michelle have been in business for a very long time, and they're always looking for providers, and we will be too. We'll always be looking to expand that, especially from our starting point right now. Next slide, please. Currently, there's over 100 providers who are currently somewhere in the application review process. 24 have submitted their applications, 15 are certified to offer services, and 13 have completed their Medicaid enrollment and are ready to provide services and to bill, more importantly for them, to bill for them. And like I say, you can track as the providers come online at the provider directory for the department. Across the 4 operating regions, we've received over 100 participant referrals. 97 have been assessed so far. 63 are referred to case managers and who then begin to develop the person-centered service plan. We've had 12 denials from the referrals, and 15 individuals have declined the services. That's kind of who we are. I know time is short, so I won't go on about much more than that, but it's a very exciting program, and we are very glad to share it with folks. Anyone can refer an individual participant to the program, be it discharge planner from a state hospital, family, friend, or the individual themselves. And that process is detailed also on our website, and I'll put all of that in the chat. Unless there's anything else you wanted me to cover, Sheila, that's our update.
I think you've done a great job, Tanya. Thank you so much. And we're excited. There are people that are actually getting services.
Yes.
At this point. Great. Okay. So you rolled out East and West with Pennyroyal and Kentucky River, and then we'll have some more in the central part of the state. So we encourage people to send in the names of people that you think could use some of the services. And thank you very much. Appreciate that.
Sheila, for the other region, I should have mentioned for the other regions who don't have services yet, we don't have a waiting list per se, but people can send an email into our 1959 initiative email box, and we'll keep that person's name and then reach out to them once we become available in their region. So thank you. Enjoyed it, folks.
Yeah, great. Thank you so much. We appreciate that. And I think next up we have I think Angela Sparrow was going to talk about the reentry program, which is another exciting program that we've been waiting several years to get launched. So, Angela.
Thank you, Dr. Schuster. Again, Angela Sparrow, I'm one of the project specialists in the Department for Medicaid Services. We can go to the next slide, please. Just to provide a couple of updates around Medicaid and Kentucky's reentry 1115 project. As you mentioned, again, there has been several years we've anxiously been waiting to implement, and we are less than 2 weeks coming up on April 1st for full implementation. So we're very excited about that and the opportunity it brings. So hopefully most of the folks on the call today are aware of the project, but if not, we'll provide just a brief overview here of what it does include. So Kentucky was approved by the Center for Medicare and Medicaid Services, CMS, in July of 2024. Since then, again, we have been working to develop the program and move towards full implementation. So the project, again, it does include our adults and all adults in our Department for Corrections, DOC state prisons are eligible, and all youth in our Department for Juvenile Justice, DJJ Youth Development Centers. Again, with the initial guidance to states, CMS did make all states aware that the opportunity really is not intended to supplant the work of our correctional partners, but really to ensure that states are collaborating and coordinating again among our healthcare systems, our judicial systems, and our communities to support individuals who are returning to communities. So under the project, again, just a reminder, it is not full state plan Medicaid services and benefits pre-release, but it is an opportunity for Medicaid, for our healthcare partners to work and coordinate with our judicial partners to provide targeted set of benefits in a pre-release period. So again, eligible individuals, they will be enrolled in a managed care organization within 60 days prior to their release, or as soon as we know they are nearing their release within that 60-day window. The approved services, again, are limited to case management services, again, to address those physical health, behavioral health, and those health-related social needs. So housing, transportation, employment, et cetera, again, up to 60 days prior to release, and then again to continue 12 months post-release. The package also, again, does include medication-assisted treatment, also known as MAT, services. So that does include medication and the accompanying therapies and counseling for individuals diagnosed with substance use disorder. And again, this is also up to 60 days prior to release, as well as a 30-day supply of medications is clinically appropriate and over-the-counter. That does include the over-the-counter medications at the time the individual is released. And so again, this initial approval, it does allow the state to begin to build an infrastructure, again, really to support that building block to hopefully, again, support expansion of the project, additional services and settings at a later time as it permits. I think we can go to the next slide, please. Again, over the course of many months, working with our MCO partners, our DOC and DJJ partners and sister agencies, we have completed, again, the program design, development of many policy and provisions to really support the implementation. So all the way from the point of entry, so that Medicaid, that initial Medicaid screening application process, suspension, all the way through, again, that eligibility, pre-release eligibility period, those services, the reentry, and then even the long-term supports. So again, working with all partners to develop those policies, those agency agreements to support data exchange, which is new, to directly interface with our DOC and DJJ partners with the Medicaid system. So we have that real-time data to support, again, eligibility determinations, the reinstatement of Medicaid eligibility, full Medicaid eligibility at release, which we know does create many barriers for our beneficiaries at entry. DOC and DJJ are a Medicaid enrolled provider. Also, again, we'll be contracting again with our managed care organizations. And so, again, they have been onboarding to the Medicaid system over the last several months, developing, again, monitoring protocols to support implementation and readiness training for our partners. So again, a lot of work has gone into supporting the implementation. So we're gearing up in the next couple of weeks, kind of wrapping up the final stages of system testing, partner testing, again, across all systems. Additional, again, hiring of staff in some areas as needed, training of staff on new policies and procedures. Really, again, our partners end to end, our state partners, our vendors, again, completing readiness assessments. Each facility, again, undergoing readiness assessments, and those final walkthroughs with DOC and DJJ and our partners in the next couple of weeks to really get us through the 4-1 full implementation. We do still have with CMS the reentry implementation plan approval pending. But again, we can continue to communicate with them. The state is permitted to move forward with implementation with that approval pending. So again, we are marching along. We are again putting in place those plans that we need to carry through, knowing that again, there will be work to be done even post implementation. This is a very large project, new project. Going back again, decades where Medicaid has not been able to reimburse for any services while an individual is incarcerated. So it is a great opportunity. We're excited about it. And again, to provide some updates post implementation.
Well, we are excited and thank you for all of your work. And thanks, Steve Shannon, who runs the Reentry TAC, the Technical Advisory Committee. And they meet on the second Thursday of the month at 9 o'clock of January, March, May, and so forth. So anybody could attend those TAC meetings and get an update. But we appreciate you so much, Angela. And as Angela said, Medicaid typically is suspended when people are incarcerated. So to be able to provide Medicaid reimbursed services for 60 days. And the other problem that we have had, and those of you who have knowledge of someone who's been incarcerated who needs medical, particularly behavioral health treatment, there has unfortunately been a drop off where people have kind of gotten lost in the system. And so we are hoping for this very strong transition into the community by having the person hooked up with their MCO while they are still incarcerated. So we're looking for great outcomes for people who have been incarcerated but have substance use disorder particularly. And we look to expand this into the county jails eventually. So it's an exciting time for the behavioral health community. Let's turn now to Carmen Hancock, who can tell us about the home and community-based waivers.
Thank you, Dr. Schuster. Good afternoon, everyone.
Hi,
Carmen Hancock. Hi there. I'm the Division Director for Long-Term Services and Supports with Medicaid. Like Dr. Schuster said, I'm here to give you all an update on the waiting list numbers for our 1915C home and community-based waivers. Happy to report there is no waiting list currently for our ABI Acute, ABI Long-Term Care Model 2 waivers, and our newest child waiver, Community Health for Improved Lives and Development, that just went live on January 1st. So no waiting list on those. Our home and community-based HCB waiver, we have 6,703 people on that waiting list. The Michelle P. waiver has 9,730 people on the waiting list. And Supports for Community Living, our SCL waiver, has 3,834 people on the waiting list. All combined, that's a total of 20,267 folks on the waiting list. But what we've done is tried to provide a little bit more accurate number here. We have people that might be on multiple waiting lists. So if we just count the people individually, that's 17,252 people on a waiting list. And of those, I did want to let you all know that of those who are on a waiting list, there are 5,175 folks who are actually already receiving services actively in another waiver program. And I will drop this in the chat. I know that that's a lot of numbers all at once, so I can take a little snip of this and drop this in the chat for you.
Thank you so much, Carmen. And
yes, ma'am.
obviously we need more waiver slots. So that's one of the asks that we're asking the legislature for. So thank you for doing that. And thanks to you all for the updates on the waiver situation. And I will turn it over to my colleague, Kelly Talby, to wrap us up.
All right. We know. Oh. Unmute. Here, we're gonna improvise. All right, I'm at Sheila's desk now, and we know we're at time. April. This is how we do it at Thrive Kentucky. We will share out slides afterwards, and please register for future webinars if you've not yet done so. Again, if you need CE credits for today, be sure to complete the evaluation. And we hope to see you next month. Thank you so much for joining.